Let you run the show.
Perfect. All right. Hi, everyone. Thanks for joining me. I am Lauren Kriz. I am a pelvic floor physical therapist. I treat out of Tampa, Florida with Cultivate Pelvic Health. With me right now, I have Dr. Alexandria Reyes. Um, Dr. Reyes is the private practice owner and founder of Magnolia Gynecology in Tampa, Florida, and also the owner of a virtual menopause care practice serving the entire state of Florida. She has dedicated her practice to midlife and menopause care, offering compassionate virtual care and comprehensive education on all menopause and uh, hormone related therapies. Um, Dr. Reyes empowers all going through the menopause transition, including survivors of hormone sensitive and gynecologic cancers, to confidently navigate midlife and make informed, personalized choices for their health, longevity, and well-being. She is a she's board certified in obstetrics and gynecology and a menopause society certified practitioner. Got that out. Uh,
Hmm. Correct.
Excellent. And why we're here today is I'm doing a series of interviews that is in celebration of National Orgasm Awareness Day, which is later in July. And so I was writing some content for social media related. This one was actually specific to midlife, when your pelvic floor after 40. And one of the changes that occurs is changes in the tissues that can impact your sexual
Hmm.
well-being, right? I was like, wow,
Right.
everybody should know about this. And so Dr. Reyes was
Hmm.
kind enough to join me and have a little conversation and share some information about what she sees and experiences, um, or what she sees her patients experience with this change. So,
Hmm.
what does it
Yeah.
mean to be a menopause specialist, and why did you choose this path? So, what does this even mean? This is kind of, it shouldn't be new, but it is kind of new, right?
Yeah. So to me, so I'm a gynecologist. So as you mentioned, a board certified GYN. So my career started that way. And then along the way, I had a good mentor in menopause medicine. A lot of patients that I inherited actually from her. She ended up leaving the first practice that I was in. And so she mentored me in menopause. And so I got interested in it that way. And then I always also really enjoyed hormones and like the fertility side of things when I was like in training. So this is kind of like the opposite side of that, as far as, this is just the end of reproductive life versus, the beginning. And to be a specialist in menopause essentially is I focus pretty much my entire practice on perimenopause and menopause hormone issues, and then also sexual medicine I do as well. But I don't deliver babies anymore. I have the certification in from the Menopause Society, so the MSCP, which is a great way to find a good practitioner in your area. So Menopause Society certified practitioner. So most people with that certification have kind of taken additional education and training in menopause and have expressed an interest in that more than the other general OB and GYN, or it can be across any specialty that you can get that certification. But that's what it means to me. It's my focus is primarily on that. So,
Fantastic.
yeah.
So, I feel like menopause and perimenopause is gaining in popularity. Just the information and content that's out there, at least all of my social media
Hmm.
right now, they're all
Hmm.
on that, which is
Yeah.
fantastic. It's kind of sad to me the amount of women who just kind of suffered through it and didn't talk about it and
Hmm.
acknowledge that it was a change
Yeah.
in life and that your body changes. But with some of this popularity, it seems as though
Hmm.
everybody's prescribing hormones right now. I mean,
Yeah.
everybody, it feels like.
True.
So,
Hmm.
what makes, what kind of advantages do you feel like you have as a gynecologist, kind of diving
Hmm.
into this specialty versus maybe somebody who hasn't been trained in specific?
Gynecology.
Yeah.
I think with OBGYN, I don't think that like menopause has to only be handled by OBGYNs, because I think that's probably where women are not taken care of to the best that they can be. But OBGYNs are well suited to take care of perimenopause and menopause issues because we're trained in like the menstrual cycle and hormonal physiology. And then, of course, like from a pelvic perspective, the pelvic organs are greatly influenced, sexual health is greatly influenced, which is all related, the vagina, the vulva. So we probably have the most training in the physical aspects of that. And then, of course, there's further specialization beyond even what you learn in OBGYN, like residency training. But I think, like, for that reason, like the physical exam that we're taught, the surgical skills that we're taught, and like the hormone physiology, I think we're taught more about that from a female perspective than any other specialty is.
So, can you
So.
tell me a little bit more about the physical changes then? What type
Mhm.
of physical changes are women experiencing in perimenopause and menopause?
So yeah, like as early as I would say on average the 40s, in perimenopause, those years leading up to your final menstrual period. So where you're still menstruating, but maybe it's regular, maybe it's irregular, maybe a certain amount of symptoms have started or not. You can start to experience the vaginal and vulvar tissue changes associated with either declining estrogen levels, which is really what menopause is a hormone or estrogen deficiency at those tissues. In perimenopause, our levels of estrogen are a little bit more erratic. So you can get highs, you can get lows, and but the tissues can still experience similar things, similar to lactation, even where you have just like low hormone levels at those tissues. Everyone's different with the way it manifests, but essentially you can get, some variety of the genitourinary syndrome of menopause, or what we call GSM now is the newest term. And so it is essentially like vaginal dryness potentially, and it's like maybe it's one of these, maybe it's all of these, but it's vaginal dryness, painful sex or penetration. You can have urinary frequency, urgency, recurrent urinary tract infections. Those are the symptoms. And the actual tissue changes typically involve like, the tissue goes from more of a pink to like a paler color. You get less thickness of the tissue, you get less moisture, less pliability, less elasticity. And so you see, like on exam, we see visual changes of that. That we can see. Sometimes it can still look normal in the early stages, but the patient is still feeling those things. But essentially, like, and then decreased blood flow as well is noted. So many common things.
So, and this is kind of the piece or a portion of the piece, right? When we think about National Orgasm Awareness Day, right? So, how does these tissue changes impact somebody's ability to have an orgasm or just enjoy
Hmm.
intimacy with their partner? I think sometimes,
Hmm.
with the clientele that I see, the patients that I treat, that they maybe they're not expecting these changes to occur where they used to be able to
Hmm.
enjoy intimacy with their partner, and then
Sure.
as they're aging, it's painful. They bleed. It
Hmm.
feels like paper cuts sometimes, right?
Hmm. Right.
So, what are some of the key things that, from your standpoint, that you do for these patients to help them kind of return to that enjoyment factor?
Well, the first thing I would say for any sexual health concern in perimenopause and menopause that I want to know is there dryness and is there pain? So are we first like laying the foundation and treating that the tissue is in optimal condition and health. So that's like step one always. It's really hard to, although the brain is our biggest sexual organ, we say, it is the whole, desire, arousal, climax or orgasm, and resolution. It certainly starts in the brain. Um, and so while that is the case, the physical tissue changes from hormone deficiency or these hormone fluctuations, even from perimenopause, they matter quite a bit. So if someone doesn't have that good foundation laid of like, okay, this isn't painful, this is pleasurable, this is safe, this is enjoyable, that's what we want to make sure we have, first, and then, we can address further issues from there. But certainly, orgasm or even sexual desire is not something that really anyone is going to want if or be able to achieve if they're having like physical tissue changes and issues there. So those really need to be optimized first. So like I'll often optimize hormone therapy first. The vaginal hormones, of course, are of utmost importance, so that we can like lay the foundation of good tissue blood flow too. So that's like one step I always, start with is, how is that part going? So it's optimized first. Um,
And when you say
so
hormone therapy, do you mean systemic, like as in taking a pill, or in local hormone therapy, as in like a vaginal cream,
well,
or both?
both, I would say. Yeah. So it depends on the person. Pretty much at minimum, I would say if like I heard something not long ago, like if your every vagina needs estrogen. So if you don't make it, you should take it. Meaning, like if you're
Oh,
menopausal or even in perimenopause, like I think at least local low dose vaginal estrogen or hormones are needed for optimal tissue health because that tissue is so sensitive to estrogen loss. So yes to local vaginal for sure, which is just the kind that where we put it, it stays, it doesn't go into the bloodstream. It's what it's treating where it's at. So the bladder, the vagina, the vulva. When we say systemic, like what you just mentioned, like a pill or a patch or even a topical gel you put on your arm or leg, something like that, that's more for like your hot flashes, night sweats, your brain fog, all other symptoms throughout your body, including the vagina and vulva and genital tissues. But I would say vaginal is like definitely very needed for most everybody. It's like preventative, it's skincare for the vagina. So that's a for sure. Whereas not everybody needs systemic hormones for all the other symptoms, but many do. And I do find that many times when you start like systemic hormone therapy in addition, like estradiol, progesterone, maybe testosterone, those things can really also help with impacting like your overall sense of well-being, which then translates to a better sex life as well. And so there's a lot of really good positive things from both sides. So from the systemic where it goes through your whole body and the bloodstream, and definitely the vaginal local hormones are really necessary for just like that tissue health you were talking about.
excellent.
So both. Yeah, in a lot of cases, both. Hmm.
So, when we talk about both, and so you had mentioned that with the local, it does not go into the bloodstream, right? It stays
Right.
right there where
Hmm.
it.
Right. Where you
I,
put it. Uh-huh.
right? So,
Hmm.
one of the things that I read recently is that when you do use the local hormone creams, that it does
Uh-huh.
not, as you just said, and I think numbers are important though, right?
Hmm.
So, if
Yep.
your estrogen is zero, your estrogen
Hmm.
remains zero, even with using
Right.
this local stuff. Because I
Correct.
think there's still a
Yeah.
lot of fear around utilizing it.
Yes. Yes. I would say for the most part, first of all, like we definitely don't have to be afraid of hormones that our bodies have made our entire reproductive life. However, in the settings of things like breast cancer or, situations in which the hormones really we don't want them elevated at that time, you're correct. Like the local low dose vaginal hormones, they're twice a week, like on average. So it's like the usual formulation anyway of vaginal estradiol. It's twice per week only. So you have this local low dose tissue treatment only. It's not in any kind of quantity that gets absorbed into the bloodstream. So they have tested, post menopausal. So after no more periods, menopause is in full effect. People who use this vaginal estrogen cream, it does not elevate their estradiol blood levels. So it proves that essentially it's staying where it's placed and not going throughout your body. So that is an added benefit to someone who, let's say, really truly can't take systemic hormone therapy, shouldn't, it doesn't want to. Local low dose vaginal hormones are very, very safe for basically all people.
That's fantastic. Uh,
Yeah.
yeah, so with kind of like the breast cancer or any other sort of menopause induced diagnoses where maybe
Hmm.
a systemic hormone may not be appropriate.
Hmm.
Is there anything else that that population should maybe think about or consider from your standpoint?
Like in
Or,
addition to vaginal hormones
yeah, or is that
or
kind of
in
like the
place
key,
of.
right?
I mean, I would say because they are safe for basically all, including breast cancer survivors, um, that is going to be something that is the gold standard of treatment for that GSM or that genitourinary syndrome of menopause. So that constellation of, bladder or pelvic, vaginal symptoms that are occurring, sexual health, staying in order, I think really needs the vaginal hormones. But there are some additional like moisturizers we'll use in addition to like Reverie is a hyaluronic acid suppository, like a collagen precursor. I mean, those products are good too, but like honestly, nothing really equates to the efficacy of vaginal hormones because it's really what, our body has needed for years to keep that tissue safe and healthy and functional. So,
Excellent.
yeah.
Thank you. Let's see. I have more questions, I know. Um, so we've talked a little bit about um, sexual desire starting with the brain, right? So if somebody does have maybe like a low,
Sorry.
you did say that,
I'm
right?
trying to sorry, I was like there was something ringing on my computer. We're good. Sorry, continue.
Okay.
Sorry about that. I logged out.
With the whole
Mhm.
libido factor, if you will,
Yeah. Mhm.
is estrogen really the big key, or testosterone or other hormones?
Both. Yeah. I mean, okay, so sexual desire or libido is a very complex situation. So, like I mentioned earlier, the sexual response cycle or desire arousal, it really starts in the brain. And so when we say that, I'm talking about like the neurotransmitters like dopamine, for example. So like that reward neurotransmitter feedback system. So the reproductive hormones like estrogen, testosterone, I would say, namely those two more than just progesterone, they affect that system. So it's not really like a direct effect. Like, yes, we need the tissue health, vulvar, vaginal to be in order and healthy, responsive, right? So blood flow to be there, which is what your vaginal hormones are doing. But in the brain itself, if that's where our sexual response cycle is starting, we really have to understand how to get that part in working order. So there's a lot of you'll hear the term biopsychosocial model when we talk about like sexual health or a sexual response cycle. And essentially, like there's such a big component that's really starts in our brains, and so that's somewhere where we have to remember. So I actually talk. Yes, we talk about hormones where they apply. Estradiol and testosterone are the biggest ones. Like when you think about systemic hormone therapy, like what will increase sexual desire or libido the most? I'd say those two, depending on the stage of where the person is at in perimenopause, menopause. Um, Vaginal hormones, and then really thinking about like what other non-pharmacologic things can increase desire. And if you look at them, they're all things that connect with novelty, our brain, making sure anxiety, depression is managed, making sure that things with our partners are in working order. That we feel safe, that it's actually pleasurable, enjoyable, that it's not the same thing every time. There's lots of layers. Um, and also I would say like medications that affect those neurotransmitters or, that can lower libido are looked at. So there's like a lot of different things we look at in regards to like, how do we treat low desire? And also it has to be, bothersome to the patient. Like not everyone needs to treat, what they perceive as low desire if they, it doesn't bother them or their partner.
Right.
But yeah, I think your question was how does does which hormones relate to it? And I would say estradiol and testosterone are the main two in menopause anyway, that we'll see increase sexual function. So it just depends on the exact issue.
Yeah. I
Um,
think you
I
brought
think
up. Oh,
testosterone's a good one for desire, but it's also um, helpful with orgasm as well. So something to think about.
okay.
Hmm.
Well, there you go. Back to that national orgasm.
Yeah, yeah.
Desire is like the first part, but it would be nice to have
Yep.
it. as well.
Right, right. Yes. If you have good orgasms, it feeds back to more desire. So typically that's, we want to prioritize that the best we can when we're talking about just like sexual health in general. I mean, one of the more common things people report is low desire. But definitely if there's any orgasm dysfunction or issue, like we have to treat that too, because we need to be able to have a pleasurable experience to then your brain say, okay, I want to do this again. It's a fun party. Let's go back. That's how I think of it, versus I don't want to go again. That wasn't that fun.
Right?
So,
Oh, I love
yeah,
that. Excellent.
yeah, yeah.
So the women who would like to maybe be a little preventative, right? So maybe they
Hmm.
are in their 40s, they're perimenopausal, they notice that things are just starting to change. Um, from a sexual health standpoint and looking at the tissues, like not many, at least not many of my patients have ever grabbed a mirror and looked
And
to
taking
see
a
what
look.
their tissues
Uh-huh. Uh-huh.
look like,
They
right?
should. Yeah, yeah.
But if they're willing, and not everybody is, and that's
Hmm.
totally okay, but
Yeah.
if they are willing to take a look and start monitoring their tissue changes, what would
Hmm.
be key things that would be maybe not necessarily a red flag, but should spark their interest to seek out help to
Hmm.
perhaps start using some sort of cream or
I mean, I would say a vulvar self-exam is a great idea. So getting a hand mirror and getting acquainted with your vulva, and at least your vaginal opening is a great idea. Your clitoris, the clitoral hood, which is the skin around that. Um, and honestly, not only just for needing vaginal hormones, but also just to detect problems. So, like you said, red flags like things like lichen sclerosis. So there's skin conditions. If the skin starts to change, if you start to feel like the labia minora they will often not disappear, but kind of, they'll lose their architecture, like in certain skin conditions or with menopause or loss of hormone. But I would say honestly, more commonly, um, you'll see just paying attention for the symptoms. So a lot of times the symptoms precede like visual changes. So you'll
okay.
see like a person report like, yeah, I just feel a little bit more dry, or that's a little bit uncomfortable with insertion, like with penetration, or sensation doesn't feel quite the same. Anything that doesn't feel quite the same, I think needs an exam like with a gynecologist, but yeah, also like taking a look at like when you feel completely normal, doing a monthly vulvar self-exam is great because then okay, this is what tissue looks like now, this is what, and then if something changes, you can see a change. If you don't know what was normal to start, you won't really know your normal, and there's a million ranges of normal. So, but yeah, I think it's more like, going for your annual at least GYN exam. And then anytime there's like a situation where you're feeling dry, itchy, pain, burning, anything that's just not quite right, even as mild as it might be, especially if it's persistent, just to think, okay, I'm in my 40s, I'm having some subtle symptoms here, I'm having a little bit more trouble reaching orgasm, I'm having a little bit of dryness with sex. Like those are reasons to go in like separate from your annual exam or get checked out with like a specialist. Um, I think people just kind of associate some things as like, oh, it's normal aging. Like I didn't think that much of it. And I think there can be so much we can do to get that proactively going because there's nothing unsafe about vaginal estrogen. So everybody like pretty much should start it as a preventative almost. I mean, at some point when they need it. So,
I have actually had a couple of patients who have had providers refuse to prescribe vaginal estrogen, which
hmm,
is I'm I know,
interesting.
right? I know.
Yeah.
So I've
Okay.
given them the American Urological Association. They have their new guidelines out on
Yeah.
the GSM and have given that to
Yeah.
them to
Good.
say, well, one, you can consider another provider. I know somebody
Yeah,
great,
yeah.
right?
Uh-huh, uh-huh.
Um, or here's some paperwork to provide.
Yeah. I
I will
think,
say, I'm a breast cancer survivor, and
yeah.
um, I need to actually make another appointment, but because I go every 6 months. So my
Okay.
oncologist, my last
Uh-huh.
with them, I was asking them about vaginal estrogen
Mm-hmm.
there as well.
Yeah.
and they still weren't comfortable with it either.
Hmm. I think if my experience is it varies a lot where clinicians or providers, doctors are at in their knowledge base on this. So there is also, you might consider for yourself or breast cancer survivors, there is a pretty good, I think it's like it's like a clinical pearl or one of these, like the American College of Obstetrics and Gynecologists have, like it basically is all the newest data. I think the Menopause Society also is a good resource. So, I mean, thousands and thousands of women have been followed over time with breast cancer. I think the data is very, very clear. I just think it's not always known. So sometimes it's just a matter of being like, so that's not my understanding. Here's this practice bulletin from a very reputable source
Right.
that, hey, what do you think of this? And I think that starts the conversation because a lot of times what I've noticed is like non-menopause specialists, they're not always aware of the different, what we mean when we say vaginal local low dose versus a systemic hormone therapy. So you have to be very clear that nobody's confused that you're thinking about systemic hormones 'cause it's a little bit more nuanced and different. But vaginal local low dose hormones are totally fine. So and I do think the data is very clear. So I could always send you those. I probably could find them pretty quick online, but I think it's just a matter of education points and like, just they're focused on breast cancer research. They're probably not thinking about, the sexual health of their patients. I wish they would be more, but after treatments. And so I think it's important that even as patients that we bring it up to our
Right.
clinicians where we get pushed back in areas that like we know are not maybe quite up to date. But it still unfortunately varies a lot in what you're told. Because I've heard your story, but I've also heard similarly, yeah, my oncologist is fine.
Right.
It's very interesting to me. Um, we're just still not quite uniform across the medical profession. And I hope one day we get there. And you have to just remember like oncologists and breast surgeons, their specialty is to treat your cancer, right? They're
Right.
to treat you surgically or to treat your actual cancer, making sure it doesn't come back, which is why they have an opinion on hormone therapy. However, again, just specifying vaginal local low dose between that and systemic, I think is huge and overlooked. And not everybody understands even the differences in those two basics. But even amongst systemic hormone therapy, remember, we have bioidentical or body identical versus synthetic, and there's different risk levels. And so it's just something that I think is not really well understood unless you truly do menopause hormone therapy prescribing. Like you don't really have a good grasp. So,
Yeah, that's fair.
yeah,
Um,
any more than I would know which chemotherapy to use, So it's kind
right.
of, I think, just part of the limitations of what we do, but I think we have to work together somehow. That's what I hope for the future, is that we can
Yeah.
all, come together on it. Because I think the overall patient matters, not just, I mean, I'm sure you feel this way, like you're glad to be treated for, your individual cancer, but you also are a whole person that has a
Right.
whole life. So,
Yes,
yeah.
exactly.
Yeah.
Exactly. So talking about working together, oh,
Yeah.
we are actually starting to run out of time, but
Okay. That's okay.
real quick, um, I had the pleasure of treating a handful of your patients, which is great. So
Hmm.
even
Yeah.
before I met you, I had
Hmm.
patients on my caseload that were coming to see you. And then since we've met,
Hmm.
I've gotten some of your patients
Yeah.
as well. So fantastic. Thank you. Um,
You're welcome.
when do you typically refer to pelvic floor physical therapy?
Pretty much every sexual health concern. So, whether that be low desire or painful sex, there's almost always some sort of pelvic floor or nerve related issue as well that I really want them assessed for, and treated for. And oftentimes I feel or find those things in their history or their physical exam. But I think like pretty much any sexual health complaint, I think can benefit from seeing you. Um, And then of course, and that's like in my world, like with menopause, perimenopause, sexual health. And then of course, if someone has, the more well-known things, I'm sure that people know if they even know about your profession, pelvic floor physical therapy, incontinence and leakage and bladder concerns and urinary frequency, urgency really benefit from your services too. And then prolapse, of the pelvic organs, bladder, rectocele, uterine prolapse, things like that. So pretty much anything. I would say I see so, I mean, most of my patients could benefit from you. I don't see a lot of postpartum, but of course, all postpartum women should see a pelvic floor physical therapist. I don't think that you're utilized enough by, everyone. I wish it was a little bit more universal, but for me, I send most sexual medicine patients to your way, and then like anyone with any kind of pelvic floor tension, tightness, pain with sex, even like clitoral issues like clitoral pain, decreased sensitivity, different things like that really need your assistance as well. So there's so many things people don't understand about their muscles and nerves in that region. So I
Yeah.
send them all to you. Yeah.
Excellent. Well, thank you.
Yeah.
Were there any remaining thoughts that you wish everybody would know that maybe we didn't cover? Are there things that you say
Um,
repeatedly over and over and over to people that you would like to share, or just anything that we've missed?
I think we covered most of the highlights. I think in general, considering this is for what a National Orgasm Day, is that what it's called?
Yep, National
Um,
Orgasm Awareness Day.
yeah, National Orgasm Awareness Day. I would just say that orgasm dysfunction historically has not had a lot of solutions to it. There are new guidelines coming out, I think, hopefully soon that like are you familiar with Ishwish? So they are like the International Society for Women's Sexual Health. And essentially, there will be some actual pharmacology options for orgasm dysfunction, which is definitely kind of a newer, we haven't really had any medication guidelines in the past. We kind of use things off label. We refer to pelvic floor therapy, but I think there'll be more and more options that more providers will be aware of in the future due to that. And so that'll be really, really exciting. But I do think, like, in general, like sexual health wellness is part of our overall health and wellness. And so, if you feel like, you're having any issues in that realm, or your general OBGYN isn't giving you the answers that you need or doesn't seem to be knowledgeable, because we really don't learn it in general OBGYN training. You need to seek out like a specialist that does sexual health, which that Ishwish website has like a find a provider tool, but essentially like find, seek answers, because there are solutions to these sexual health concerns that, they do get brushed under the rug a lot, even by your regular OBGYN. And sometimes it's that they don't know, or maybe it's a time issue, or we try to bring it up at an annual wellness where there's just not time to dive into these sexual health complaints and concerns in great detail. So that would be the other thing I always advise is like sexual medicine or menopause, perimenopause hormone concerns, like go make a dedicated appointment for that problem to get the best attention. And if you still don't get the answers you're looking for, then finding another provider. But I do think women don't realize that they bring these things up at like these abbreviated, wellness visits. And so I hear that a lot in my practice, where they came from a different provider and they're just sort of disappointed that it didn't get addressed. And I'm like, I think some of it's knowledge, but I think some of it's also like it's being brought up in the wrong setting. And nobody knows that unless you tell them. So
Right.
that would be my advice, is always try to see your provider at a dedicated visit. And if you're still not getting what you need, despite trying to advocate for yourself, then you need to find somebody new. And I'd be happy to see anyone in Tampa or the area. And then, of course, like throughout Florida, like you mentioned in the beginning, I can see anyone telemedicine as well, which works really, really well for like just perimenopause, menopause. We can even do some vaginal hormones that way too. So that's fine. Whatever we can do to help increase
Excellent.
access. Yeah.
Great. Thank you.
Yeah. You're
I
welcome.
greatly appreciate your time today. Um, and so if you need anybody that needs extra help, go see Dr. Reyes. She is phenomenal. Again, every single one of the patients that sees her absolutely loves her. Um,
Oh, thank you.
you're
That's nice to
welcome.
hear.
Excellent.
Mhm.
All right.